Welcome back to this next video in which we are discussing hyperthyroidism. So in the previous video we discussed some of the major causes of hyperthyroidism, and in this next video what I want to move on to discussing is some of the major symptoms of hyperthyroidism and some of the major presentations of hyperthyroidism. We'll end the video then by discussing the treatment for hyperthyroidism. So let's now discuss some of the symptoms of hyperthyroidism. So, remember the physiology that we discussed in the hypothyroidism video. We said there that thyroid hormones are responsible for regulating the basal metabolic rate of tissues all over the body. And the higher the thyroid hormone level is, the higher the basal metabolic rate is going to be. So in hyperthyroidism then, the basal metabolic rate is going to end up being too high. You're going to end up burning through calories at a much higher rate. So what this is going to lead to, in contrast to hypothyroidism, is it's going to lead to weight loss, whereas hypo led to weight gain. It's also going to lead to increased heat generation because a lot of the calories that we burn, the energy is converted into heat energy. So you're going to end up with heat intolerance, and this is a very common occurrence in hyperthyroidism, that people end up very, very hot and they don't like hot weather at all. They much prefer winter to summer. And of course, if you've got heat intolerance, what you're also going to end up with is sweating far too much. So the fancy name for excessive sweating is hyperhidrosis. So excessive sweating, heat intolerance, weight loss, all because the basal metabolic rate is now too high. Now, let's think about the effect that it's going to have on the heart. Basal metabolic rate going up in the heart is going to increase heart rate, and it's going to increase the force with which the heart contracts. So you're going to end up with heart rate going up, so they might end up slightly tachycardic compared to their normal heart rate. Because heart rate has gone up and stroke volume goes up because inotropy goes up in the heart, that will lead to blood pressure going up. And we have a fancy name for cardiac output being increased, which is what's going to happen if heart rate and stroke volume go up. We can call that hyperdynamic circulation, and that simply means that the heart is pumping a lot of blood around the body. So hyperdynamic circulation refers to cardiac output being too high. And one of the consequences of hyperdynamic circulation is that the skin can end up flushed. So this is another one of the symptoms of hyperthyroidism that people often complain of, that their face and their hands are quite red. And this is because their blood pressure is too high, because their cardiac output is too high, because they have the hyperdynamic circulation. So let's change colour to make it a little bit more interesting. So we've talked about some of the major consequences of BMR going up. Let's now examine the effect on the gastrointestinal tract. Oh, actually, before we do, let's stay on the heart. So I said in the previous video on hypothyroidism that hyperthyroidism is rarer than hypothyroidism, but hyper is more dangerous than hypo. And the reason it is more dangerous is because the effects that it can have on the heart. So in many people who have hyperthyroidism, they don't get the dangerous manifestations that it can have on the heart. Their heart rate goes up, they might end up with hyperdynamic circulation and raised blood pressure and flushed skin. However, the really dangerous manifestation that can occur in some people is that you can end up with cardiac arrhythmias, the most common one being atrial fibrillation, AF. Now, in case I've got viewers who don't know what atrial fibrillation means, the atria are the two small chambers of the heart, and fibrillation means that they are not beating correctly. Instead, they are shuddering. So, of course, the chambers of the heart should contract down to a nice small size and eject blood out. Instead, in fibrillation, what they do is they just sort of shudder, they vibrate, but they don't actually contract properly down. So in atrial fibrillation, the two atria of the heart are, instead of contracting properly, they are just shuddering. Now, this is not actually too detrimental to cardiac function because you don't actually need the atria. You could design a perfectly good human heart, and indeed many animals have perfectly good hearts where they just have the ventricles, they don't have the atria. So the fact that the atria are not beating correctly doesn't actually have too much effect on the function of the heart. As long as the ventricles are okay, that's fine. The problem with atrial fibrillation is that the electrical activity has gone completely off in the atria. That's the reason that they shudder in this way, because the electrical activity has gone totally haywire. And you can see this when you do an ECG. You see the baseline just shuddering, and that's the shuddering electrical activity that is causing the actual physical shuddering of the atria. The problem is that this haywire electrical activity can end up being conducted down to the ventricles, and the ventricles can then end up beating very, very, very fast, rates of way over 100, ranging up to maybe 150. So you can end up with very, very fast tachycardias, and that is known as fast AF. So when atrial fibrillation actually results in the ventricles beating far too fast, that's called fast AF. And that will manifest with palpitations. Blood pressure will usually collapse down because if the heart's beating far too fast, it doesn't actually have time to relax down between contractions, so it ends up contracting again even though it's only relaxed a tiny bit. So that means that it ends up actually only ejecting a tiny volume of blood. So cardiac output usually collapses when your when your heart rate goes ridiculously high. Such as if you're in fast AF. So you may get palpitations, you may start to feel faint, you may even faint because your blood pressure has gone down so much, and that would be called cardiogenic syncope. So I'm just going to write some of this down. So this can result in palpitations, and if you're lucky, that would be the only manifestation. So if your heart's going fast but your cardiac output's okay and your blood pressure stays up, all you'll feel is palpitations where you feel your heart pounding very, very fast in your chest. But if you're unlucky, you may well get cardiogenic syncope, which is where you faint because your blood pressure has collapsed because cardiac output is reduced so much because the heart's beating far too fast. Now, it's rarer, but another arrhythmia that you can get is ventricular fibrillation, which is where fibrillation happens but in the ventricles. Now, this is not compatible with life. If the ventricles do that, then your heart stops beating. You go into cardiac arrest, which is the medical term for the heart has stopped beating. So ventricular fibrillation is a medical emergency. If it doesn't stop, pretty soon you will die because your heart won't be pumping any blood around your body, and your brain, if it doesn't get enough oxygen and glucose, will start to die. And if your brain dies, you die. So thyrotoxicosis can actually result in ventricular fibrillation. It's rarer than atrial fibrillation, but be aware that it can result in that and then cardiac arrest. So these are both extremely serious manifestations of the basal metabolic rate of the heart going up, extremely serious manifestations of thyrotoxicosis. So be aware of those. They are what make thyrotoxicosis dangerous. Now, basal metabolic rate going up in the gastrointestinal tract then. What are the effects there? Of course, we saw hypothyroidism, lower basal metabolic rate in the gastrointestinal tract, reduced movements and caused constipation. It's the opposite problem here. The gastrointestinal tract is going to wriggle around far too much. It's going to move contents through far too quickly, and you're going to end up with diarrhea because you don't have time to absorb the water properly. So diarrhea is a common manifestation of hyperthyroidism. Now, let's talk about the neuropsychiatric effects then. So in hypothyroidism, we talked about how it makes people feel tired, it often makes them feel a little bit depressed. What are the manifestations neuropsychiatrically for hyperthyroidism? Well, it commonly makes people feel quite irritable. That's a very common presentation, that they're just very snappy, very short-tempered, irritable. Also, it can cause problems with sleep because your basal metabolic rate being so high means that your body finds it more difficult to go to sleep. So insomnia is another common problem in hyperthyroidism. Problems getting to sleep and problems maintaining sleep Also important, anxiety often goes up in hyperthyroidism, and essential tremors can develop in hyperthyroidism. So you can become quite tremulous. And those are all the symptoms of hyperthyroidism that I'm going to discuss. They are the main ones. Let's now discuss which of these form major presentations. So what are the major presentations that you should consider hyperthyroidism? Obviously, if someone has a goiter and is displaying any of the symptoms of hyperthyroidism, you should absolutely consider hyperthyroidism. That's a definite presentation. If you see someone with a great big goiter, it's a thyroid problem. You need to investigate that. You absolutely need to do their thyroid levels and find out whether they're hyper or hypothyroidism. Okay. As far as the symptoms are concerned, let's say they don't have a goiter but they're just presenting with symptoms, what are some of the common presentations? If they have gone into fast AF or some sort of cardiac arrest, then that warrants a check for hyperthyroidism. So that is something where you would measure thyroid levels. In addition, a common presentation is for people to present with heat intolerance and sweating and flushed skin. So all of these are presentations where you should consider hyperthyroidism. So if someone's coming in with excessive sweating, of course, an alternative diagnosis is that they have idiopathic hyperhidrosis, and many people who have excessive sweating, it will be that they have idiopathic excessive sweating rather than hyperthyroidism. But definitely, if they present with hyperhidrosis or heat intolerance, they need to have their thyroid levels checked to check for hyperthyroidism. But I will just write down here that hyperhidrosis will often be due to primary hyperhidrosis rather than hyperthyroidism. And primary hyperhidrosis is just idiopathic hyperhidrosis. In addition, if someone comes in with irritability, problems sleeping, anxiety, or essential tremors, all of these presentations, if they're new and not long-standing, they may warrant thyroid levels being checked. So all of these are potential presentations for hyperthyroidism that should warrant thyroid levels being checked in the blood. So let's now talk then about the treatment for hyperthyroidism. So the treatment consists of drugs that are capable of inhibiting the production of thyroid hormone by the cells of the thyroid gland, and we call these drugs antithyroid drugs. And the two major examples of antithyroid drugs are carbimazole and propylthiouracil. So carbimazole and propylthiouracil, which for short, because it's a bit of a mouthful, is often abbreviated down to PTU. Now, these drugs, both of them work by inhibiting an enzyme that is involved in the production of thyroxine by the cells of the thyroid gland. So in here, there is an enzyme called thyroperoxidase, the TPO enzyme. So this stands for thyro, that's the T, and then the PO is for peroxidase. So this enzyme is crucial for the production of thyroxine by the cells of the thyroid gland. And these drugs, these antithyroid drugs, you can also call them TPO inhibitors because that's exactly what they are. They inhibit this enzyme, thyroperoxidase, and hence they're going to inhibit the production of T4, and hence they're going to stop the hyperthyroidism. They take quite a few weeks to work. People often estimate that you'll start to see proper effects between 6 and 8 weeks of taking the drug. And that's because if you remember your more in detailed thyroid gland physiology, you will know that actually it's quite complicated, the production of thyroid hormone. The thyroid gland consists not of individual cells functioning on their own, but these cells are arranged into massive circular follicles, and they produce a substance called thyroglobulin and put this in the center of the thyroid follicle. And this thyroglobulin contains, it's massive great polypeptides that contain a huge number of the thyroxine and even triiodothyronine molecules within them. So they actually produce a huge store of thyroid hormone before they actually release it into the blood. Then, when they want to actually release it into the blood, they take some of this thyroglobulin that's stored in the centre of the follicle and they break it down to release the thyroid hormone, and they then release that into the blood. So the thyroperoxidase enzyme is needed to synthesize the thyroglobulin. So I'll just write this here. It's needed to synthesize thyroglobulin, which we abbreviate to TG. Whoops, missed out the L. Globulin. And we store a huge amount of thyroglobulin, and that's why these drugs are going to take a while to work, because they're going to inhibit the production of thyroglobulin, but you've still got that huge amount of thyroglobulin that's already been produced and is being stored in the follicles that the thyroid cells are going to work their way through before they're going to run into a problem because of the drug inhibiting the thyroperoxidase enzyme. So that's why it can take quite a while for these drugs to actually work. As well as that, the half-life of thyroxine in the bloodstream is about 7 days, so it's quite a long half-life. So it actually takes quite a long time for the thyroxine levels to even come down in the blood themselves, because it's only taken out of the blood very, very slowly. So be aware of that. So those are two reasons why it's going to take quite a while for antithyroid therapy to actually take effect. But it will take effect in the end. It will stop the thyroid gland producing the thyroid hormone eventually. So those are antithyroid drugs. They are not particularly nice drugs to take. Carbimazole can have the horrible side effect of stopping the production of neutrophils by the bone marrow. So you have to be very careful and watch out for neutropenia, because if you get neutropenia, that can hugely weaken the body's immune system, and infections that previously would have been fought off easily can become very, very serious and potentially very dangerous. So you have to watch out for neutropenia as a possible side effect of carbimazole. Propylthiouracil is usually the second-line drug. Carbimazole is usually the first-line one, and if people can't tolerate carbimazole, they move them onto propylthiouracil. Other thing to know about propylthiouracil, it's the one that someone would need to take if they were pregnant. So if you have a lady of reproductive age who has hyperthyroidism, is on carbimazole and wants to try for a baby, they need to be moved onto propylthiouracil off carbimazole, because carbimazole is teratogenic, whereas propylthiouracil is safer in pregnancy. So that's the one that would be used in pregnancy. It's also the one that would be used in people who can't tolerate the side effects of carbimazole. So antithyroid medication is the first line of treatment, but we can also actually try and destroy the thyroid tissue so that you will end up producing less thyroid hormone. Oh, and I need to say something more about antithyroid therapy. So often there is a certain strategy that is used, which is block and replace. This is the sort of doctrine, philosophy that many endocrinologists use when they're treating hyperthyroidism. So what's this all about? Well, if you give someone an antithyroid medication such as carbimazole, it's very, very difficult to titrate it perfectly so that the amount of drug that you're giving is going to reduce thyroid hormone levels perfectly to within the normal range. Instead, what is usually more achievable is giving them a large amount of the drug to completely stop all thyroid hormone production by the thyroid gland. That's what we mean when we say block. So we're going to completely stop all endogenous production of thyroid hormone, and then we're going to replace, so that means putting them on levothyroxine to replace what they're not producing. So often people on antithyroid medications, they will end up being given a large dose of the antithyroid drug to completely stop all endogenous production, and then will replace the thyroid hormone with levothyroxine. That usually works better than trying to actually just tailor the amount of antithyroid medication down so that it inhibits the thyroid gland enough, but still doesn't inhibit it fully so that it can produce enough to make you euthyroid, which means perfect thyroid levels. And that's a word that I haven't actually used in either of the videos yet, so I'll just write it down for you. So we describe patients who have normal thyroid hormone levels as euthyroid, as opposed to hyperthyroid or hypothyroid. So the whole idea of the block and replace strategy is that it's very difficult to tailor these drugs down so that you reduce the patient's thyroxine levels to the euthyroid level. Instead, what we do is we completely give them a large dose so that we completely stop all production of thyroxine by their thyroid gland, but then of course they're going to be profoundly hypothyroid, so we replace with levothyroxine, which is much easier to titrate than the antithyroid drugs. So that's the block and replace strategy. Now, the two next things that I'm going to tell you about, they also employ the block and replace philosophy. So they are, let's destroy the thyroid gland, basically. So what we can either do is we can destroy it with radioactive iodine, which we abbreviate to RI, so we can use radioactive iodine ablation, or we can do a thyroidectomy, and we discussed this in the video on hypothyroidism, that one of the causes of hypothyroidism is having your thyroid removed for hyperthyroidism. So, in radioactive iodine ablation, a radioactive isotope of iodine is given to the person. Iodine is taken up by the thyroid gland because it's the major point in the body that actually uses iodine to produce the thyroxine hormone. And then once it's been taken up, it's going to decay, release radiation that's going to kill the thyroid cells and therefore result in the death of a huge amount of thyroid tissue, potentially the entire thyroid, but at least some of the thyroid tissue. And of course that is going to reduce thyroxine production once we've destroyed some of the thyroid tissue. Now, if the radioactive iodine ablation fails to destroy all of the thyroid tissue, then you'll still have some endogenous thyroid production, so we'll have a look at that. It might just happen that we do it perfectly and you end up totally euthyroid. You've got just enough thyroid left to produce the perfect amount of thyroid hormone and you end up euthyroid. Brilliant. More commonly, we employ the block and replace strategy because tailoring radioactive iodine ablation to try and make it perfect is very, very difficult. It doesn't work. So instead, usually the strategy is to just destroy the entire thyroid gland and then replace with levothyroxine. So in fact, radioactive iodine ablation, you could add that onto the list of things that can cause hypothyroidism because it's another way in which you can destroy the thyroid gland iatrogenically. Thyroidectomy is where surgeons, general surgeons usually, go in and remove the thyroid gland, and then, of course, you have no thyroid gland, you won't produce any thyroxine anymore. So, again, this will be using the block and replace strategy. We'll put you on levothyroxine and titrate that so that you are euthyroid. So that then is the treatment for hyperthyroidism. Thank you for watching this video. I hope that you've enjoyed it.